pictures of Dr. Wasek Faisal, especially Wasek, nicely shown how you treat the patient with the early stage lung cancer. So now, as you know, every centers, every country needs the data. What data you have regarding your lung cancer molecular profiling. So I was thinking for the last couple of years whether we can put some data where we can give the reference for that. So in our centers where I'm working with our oncologists, with our respiratory medicine specialists, we made some documentations about the NGS. So if you see the globe, you can see the pocket of cancer in the world. Like in South Carolina, breast cancer is more. In the Europe, you can see the esophageal and other cancers is more. In the Asia, you can see especially the head neck cancer is more, cervical cancer is more. So what about the scenario of the lung cancer? You can see in America, there's a high number of the lung cancer. And in Europe, there's a bulk of lung cancer is more. And if you see the Asia, especially East Asia and our region, you can see there are about 62% of the lung cancer is in Asia. So Asia has a big number of the lung cancer. So we'll have to think about how we can get our database regarding the mutation and other things, how we can treat the patients, because we are treating the patients with all the European and other guidelines. So you can see the near about in Asia, in 39% in East Asia, and if you include the China has more than 40%. If you include total Asia, Asia has the bigger number of the lung cancer incidence in this region. So what about lung cancer across Indian Asia? You can see in Bangladesh near about 8.8% as per Globocan studies, and India has a bit lower, 5.8, and China has a 40%, 40, and Japan, Korea, and Myanmar has a more than our countries. So bigger number of the lung cancer occurring in this region in the Asia. So why molecular profiling matters? What was the yesterday? Yesterday was a one-site fit for all. Especially platinum-based chemotherapy has given in all type of lung cancer. But what today's concept? Today's concept is genetic signatures. You can see the target. Every patient needs to see the genetic landscape of the patients, and you can think about the right patient, right tumor, right drugs in the right times. So there is a paradigm shifts from one-site fit all to precision oncology. So what's the benefit? You have seen the benefit in terms of survival, in terms of toxicity, and also the trial. So we did near about 270 patients in our specialized hospitals, but we did a multi-center like Asani Mission and Chittagong Mao Shishu, but we have excluded that one in these presentations. If you see the right sides of the graph, you can see the World Lung Cancer Conference and ISL studies that shows the Asian population has more mutations than the European. In the inner circle, you can see the inner circle has a European mutation, and the outer circle has the Asian. So Asian population has a different type of mutation than the other parts of the globe. And if you see our center, Bangladesh Specialist Hospital, BSH, we had a near about 44% of the patient has the EGFR mutated cases. And if you see the Korea, that has a 60% EGFR mutated cases. Japan has a 35% cases. So in Asia, there is a pocket of EGFR mutated regions, and where you can treat the patients different. In Bangladesh, we doesn't know the Teknaf people has one type of mutations. The Tetulia people has a different type of mutations. So we need to see what type of mutations had each and every patient of your community, of your centers. So we are trying to document in that cases. We studied near about 270. We are giving this document from the single centers, and we have gathered 4 centers. So to do this, you need to do the comprehensive genomic study. So how will it do? We don't have in our country the NGS lab, because we had to send 100% from our centers the tissue to CAP accredited centers, and you can see we have sent out of all tissue to different centers to the neighboring countries. Some patients went, there were 78 patients went with their own tissues to the different centers in the neighboring countries or other countries, and 154 patients we have sent to the Newburgh in India, and 16 patients we have sent to the Foundation One in the USA. So out of that, so we got the mutation status of our patients of single centers. So what is the gap we need to close here spatially? We need to close this gap. We don't have a NGS lab in Bangladesh. We don't have a CAP accredited lab in Bangladesh. One thing, CAP accredited CBC centers doesn't mean the CAP accredited NGS lab. So CAP accredited NGS lab should be a different one. There should be ISO 15189 certified, not others, because the steel company has also ISO certifications. And another thing is there should be CELIA accreditation, like clinical laboratory improvement amendment. So you'll have to see which lab you are sending your tissue, because your tissue is a very precious. It's like a diamond. So we need to build our NGS lab in our Bangladesh. We need to train molecular scientists. We need to do our Bangladesh mutational variant database or landscape of the mutation status of the Bangladeshi patients. Maybe we have a different type of mutation than India or Korea, Japan, Europe, and America. So it should be affordable. The patient can afford, because everything had to bear from his own pocket. So let's have a bird's eye view of the different hospitals. As we don't have any national cancer registry, we had some hospital-based cancer registry like Cancer Institute, Asan Mission Cancer Hospitals. In our hospitals has some type of shortcut history or documentations from where we can extract the data. If you see the lung cancer, not incidence, lung cancer frequency in Asan Mission Cancer Hospitals in 2025, you can see near about 7,000 patients, 12.3% of the patients are diagnosed with the lung cancer. And this is the most common, second most common cancer in Asan Mission Cancer Hospital. And you can see the profile of the patients like smoking habits and other. What about the National Cancer Institute? This is the biggest center of the country. And they published in 2025, 30,000 new cancer cases has registered in national cancer centers. Out of that, 15%. So we are getting 12% in Asan Mission, 15% of the total cases of lung cancer in National Cancer Institute. And you can see the other profile of the type like squamous, adeno, and others. So what about in my institute? These are very small centers, but we have documented near about 14,000 cancer patients. And out of that, 1,710 lung cancer, we had 11%. Asan Mission has 12%, we had 11%, and Cancer Institute has more. And out of that, out of 1,710 patients, we can do 16% patient with the molecular genetic signature study, like NGS or comprehensive genomic profile. So, and mostly patients are in advanced stage. You can see in advanced stage means as advanced age, like 50 and 60 years. And you can see the why the never smoker is more. Because when the patient comes to the hospitals, in the like corporate hospital, patient doesn't want to say, yeah, I am a smoker. I have taken 1 or 2 stick of smoking in a life and other things. So even documentation maybe we have a lacking because we had not documented the smoking habit in that case. So we had never smoke is more in our study. So histological type in our hospital, you can see the adenocarcinoma is more, near about 74%. We studied on that, especially on the NGS, and mostly patients are in the stage 3 and stage 4. So early access patients, very negligible numbers where we can perform the surgery and other things. In our centers, initially, we don't have a NGS available. So at that time, I did some, near about 134 patients, I did the PCR study. And you can see the 134 patient, 89, we have a biomarker positive. And very interesting thing is that you can see there is a 28% ROS positive in PCR. And ALK is near about 29%. Very absurd result. So we think, what should we do? This is a PCR study from Bangladesh lab. So from then we started to do the NGS. We send the starting sending the patient to centers which is CAP accredited. So this is the molecular landscape of our 274 patients. We did the comprehensive genomic profile and NGS, and you can see we got 100%, there are 36% EGFR positive, 21% TP53 positive co-mutations, and 10% KRAS, and 5.8% ALK, and also some rare MAT HER2 positive cases also. So, and we analyze what are the EGFR subtype mutations, especially like the exon 19. We found near about 54% patient has a exon 19, and 11% has a exon 21. So this is our centers where exon 19 positivity is more, especially in the advanced cases. And as you know, PD-L1 staining is very important, but 49% of the patients we can do the PD-L1 studies, and there is a gap. So half of the patient we cannot do the PD-L1 studies. At that time, PD-L1 study was not available, but now is available in our centers. We can do the PD-L1 study. So we can, and out of that, 28% is PD-L positive, and 23% was PD-L negative. So in that cases, some cases we can start the IO therapies. So we started to see the response rate. We have found when we are giving the first line therapies, patient has getting a more complete response and also partial response. And gradually when we're using the third line and others, is dropping down. So using the TKI in our patients, 32 patients with osimertinib and other afatinibs and other drugs, we have seen near about complete response near about 8 patients. We have evaluated 64 patients till now. We are seeing the patients which are giving the TKI, which they have a mutation, they are having a better result than the others. So when we are using the TKI in the first line, 68% has a responding good, and 50% when we are using TKI in the second line and third line, gradually the result is not that much effective. So each subsequent line responses drop as a mutations that are emerging. So some rare mutations we have seen some cases where, especially the HER2, though HER2 result came after 1 month, we have started the chemo and others. When we found the HER2 therapy, at that time, anti-HER2 therapy is not available in Bangladesh, which is especially deruxtecan, very expensive one. We started some anti-HER2 therapy along with the chemo, but we found the patient actually has a very bad prognosis, and patient gradually advances. Even we have used some afatinib in that cases. We have seen some partial response, and also some cases stable, but ultimately patient had not that much good result, usually especially the patient who have a HER2, that's the right type of mutations. So we have tried with the common drugs which are available. So similarly, in KRAS, I think we had some small number of the KRAS mutation patient. So we started with the chemos and others. Then after chemo, we know the the TKI therapy is approved in that cases. We tried to do the TKI for the KRAS, but we didn't find a better result with that one also, the KRAS. And we found that HER2 positive and KRAS, these are very aggressive type of tumors. Even one thing is that the KRAS tumors, HER2 tumors, when we start the premix-based chemotherapy, it doesn't work actually. Because when we started the we sent the patient for the core biopsy, we started the premix-based chemotherapy, result came as a HER2 positive, we had to shift to other chemo or anti-HER2 therapy in that cases. So that is two cases where we found especially the HER2 therapy has a bad prognosis, KRAS positive, G212 has a, we have started the total CPOP, so our experience was not that much. The progression is more, especially bone and liver. So we tried with two cases, HER2 and also KRAS mutation. We have seen these are the two types of rare mutation that has a very bad outcome, even we use the TKI and others. So from this, our NGS data from the single cells, what we actually got the ideas. We got the ideas actually in near about 30% of the patients, there is 1 in 3 has EGFR mutations, and where we can use the TKI. We found that near about some percent of the patients has a PDL positive, we can use the IO therapies, and in one sense, we has got a bird's eye view of a single centers. There's mutational status should be done in every lung cancer cases, and going for that, doing a single PCR and other stays, NGS is better to get the total mutation status. So I think we should acknowledge our patients who have given the tissues, and also the physicians, surgeons who have sent the patient to our centers. In the study team, we are actually putting the data for our records, and we don't have our institution, especially the Bangladesh Special Hospital, who have given the permission to do this type of documentations and to present this data in conference and others, and we don't have any fundings. So I think we have given some ideas about the molecular landscape of a single centers, and gradually we can show how the Bangladeshi patients have a mutations which is nearly equal or common or different from other regions of Asia. I think, thank you all.